So, ascites, one of the commonest symptoms that we see in patients that we manage, and very challenging. The nutritional consequences. Patients, it's been demonstrated in studies that your resting energy expenditure increases with the presence of ascites. If you can imagine having 8 litres of fluid in your abdomen, you've got to carry that round, which makes you expend more energy, but also you've got to keep it heated to body temperature. So that takes quite a lot of energy, and in the form of heat that's generated to keep that at body temperature. So it increases the resting energy expenditure. The studies have said that it's an average of 10%. In practice, it feels a lot more, and that you do see that muscle just drops off people once they develop ascites, even if they're not paracentised. The other mechanism for that is probably early satiety in just the sheer volume of the ascites and pressing against the stomach and reduced intake because of that. Nausea and vomiting, again from the same mechanism of lack of space, and increased protein losses because the acidic fluid is very rich in protein, and muscle is often liberated to try and make up the perceived deficit by the body, and then gets sort of sucked into the acidic fluid essentially. And it can be quite high. I mean, we've had 20 grams per 100 mils, we've had 10 grams per 100 mils. So if you times that up over litres, it's phenomenal. Some are much lower, so that it's, say, 200 grams of protein for every 10 litres of ascites. But if you times that up into what someone's missing, that over a week, that's an extra sort of 30 grams of protein a day if they're being paracentised on a weekly basis. So I think it's just to be aware of that. And in patients where you feel you can't keep up nutritionally, you can send a sample of the acidic fluid to biochemistry, and they'll give you an estimation of the protein content. So that's useful, just to be able to dot the I's and cross the T's. Muscle wasting is evident in people with ascites, sometimes with nutritional support because the requirements do increase. What we've found is that with adequate, consistent nutritional support in the form of oral or enteral feeding, if you meet the daily targets for protein and energy, you're taking the job of feeding the patient away from the liver, so reducing the work of the liver. You seem to get recovery to an extent, and that extent depends on disease severity and other factors. But for an example, we had a young lad, early 30s, listed for liver transplant, alcoholic liver disease, been abstinent for just over 6 months, and he was having about a 10 or 15 litre paracentesis every fortnight. And there was a lot of debate whether we should improve his nutrition and watch, but then what if he decompensated further and missed the window for transplant? So it was agreed that he'd be listed, and if he improved, we could delist him. Well, we supplemented his protein. He loved ready-made milkshakes, fortunately. The supermarket bought ones as opposed to supplements, and he would drink about 100 grams of protein a day. Didn't really eat that much, bits and bobs. So his intake was probably about 140 grams of protein. His dry weight was about 65 kilos. So 2 grams per kilo is about what he needed. And he, in the space of 4 months, he's put on 5 centimetres of muscle. It was 3 centimetres at the first review, which probably took us sort of 2 and a bit months to see him. And then a subsequent review, we'd put on another couple. And his hand grip had improved dramatically. But the biggest impact was the fact that he was no longer accumulating ascites. So he's now off the transplant list. Part of that is in relation to patients with alcoholic liver disease. We used to think that maximum liver recovery was about 6 months after being abstinent, so taking away the driver for the liver disease. But we now are seeing that if we couple that 6 months with nutritional therapy, that you get prolonged recovery from alcohol. So it might not be maximised at 6 months, and it might be worth extending that duration to see what maximum recovery you're going to get. So it's to say that there is worth in being aggressive in meeting people's nutritional requirements, because you can reduce the volume drained, or you can reduce the frequency, even if you don't prevent them from getting ascites, and you can reduce edema as well through meeting protein requirements. When it comes to salt, we do get patients referred on very, very low salt diets. We had somebody in clinic that we'd assessed in August who came back a centimetre and a bit of muscle lighter and much, much weaker. And he'd been advised on a very low salt intake, so that he'd even, well, he was just hardly eating anything. You get people that go onto the internet as well. I had a lady the other day who'd read that she shouldn't have any protein with liver disease, so she was on a no protein diet, near enough, but she likes protein, she didn't want to eat anything else, and her hunger, it was about 8. So, and she's not even really that decompensated at the moment. So there are different reasons why people end up on strange diets. But with regard to salt, the studies show that you get faster resolution of ascites if you restrict salt. That is true. But the studies also show that you get a much poorer energy and protein content of the diet, and that has a devastating effect on nutritional status. One study has shown that there's this optimal, it was a Runyon study, 88, very precise. This was the optimal amount coupled with diuretics to be able to induce diuresis. So you've got to think of all those things in the context of what I was talking about this morning, with the severity and all the numerous factors that cause malnutrition in this group of patients. So if we are going to salt restrict somebody, what's their social circumstance? Salt, foods low in salt are much fresher. You can't have anything packet, processed, ready-made, cereals. It all has to be fresh. It has to be therefore fresh bought. The people have to go and get it, have to have the money to buy it. They've got to have the facility, the wherewithal, the motivation to cook it. If you are being paracentised, that volume of ascites, every couple of weeks, you've got to take that out shopping with you to buy the food. What if there's no lift where you live, if you're on the 2nd or 3rd floor? There are so many barriers to following a low-salt diet that we have to match the treatment of the ascites with the stage of the malnutrition, the stage of the disease. If somebody is in that position and they're intolerant to diuretics, is taking away all their salt going to make much difference? It doesn't by the time you get to this point. Making sure someone's not eating salted nuts, having crisps, crackers with visible salt, or pouring salt on their dinner, or having OXO drinks, those things, yes, fine. Try and get rid of those, and if they're having a lot of takeaways, but prioritise the higher quality nutrition foods over those in that equation, meaning that let them have packet ham, tinned meat, tinned fish, processed stuff, ready meals. You could cook with a pinch of salt, or they don't cook with a pinch of salt, but they have gravy. Or they make pasta and they have a ready-made pasta sauce, but they don't cook with salt. So it's just adding a source of salt to try and minimise the impact. But where someone's appetite is extremely poor and they're very malnourished, bar making sure that someone isn't having soup, OXO, crisps and salted nuts every day, we don't salt restrict. It's just sensible advice. So what we do is prioritise meeting the energy and protein requirements and just be sensible with salt. So low salt diets are a no-no. We don't recommend them. Encephalopathy. We all know there was a myth that high protein diets caused encephalopathy. When we look at the admissions of people with encephalopathy, they're constipated, they have diarrhea, they could be septic, it's an acute decompensation. You don't get people admitted after having a mixed grill or a cooked breakfast or downing a 4-6 compact protein. You don't see any of that. Encephalopathy is rarely precipitated by boluses of protein. It's precipitated by a metabolic derangement, increase in ammonia, usually through one of those precipitating factors. So you get more nitrogenous waste from restricting protein and breaking down your muscle than you do from the waste product from dietary protein. So the protein restriction was born of a myth from a a study in the 1950s where they induced encephalopathy with urea-containing substances and then restricted their protein and incrementally increased it over days. And it just so happened that the time lag from inducing the encephalopathy to them improving coincided with the 40-gram protein day, and there the myth was born that everybody followed for the next sort of 20 or 30 years to the detriment of our patients. So by people that are malnourished are more likely to have refractory encephalopathy, meaning that they bounce back into hospital with encephalopathy far more frequently. Any sort of minor metabolic derangement can immediately cause them to be encephalopathic, or they might have ongoing chronic encephalopathy that they just can't completely get rid of with lactulose and rifaximin. Rifaximin's wonderful, but more with lactulose. And this is partly because when you waste your muscle, you lose a mechanism to detoxify and clear ammonia. We forget, we think that the liver just converts ammonia and water to urea, and that's the only excretion. There is some renal excretion, but also the muscle will detoxify and convert it to glutamine. So when you lose your muscle, you lose a mechanism to get rid of ammonia, and you become more encephalopathic. We had somebody that was listed for transplant for recurrent admissions from encephalopathy, very brittle, in and out, once, twice a month. Malnourished, probably, I think he was a 5th, 10th centile from memory, went home on NG feeding. He's been off the list 6, 8 months now. So we increased his muscle mass by about 2, 3, 4 centimetres. He's not been encephalopathic since. He's now controlled on lactulose, and he's off the transplant waiting list. He put on about 12 kilos. So you can change that situation with aggressive nutritional support. So there are some dietary checks to minimize muscle catabolism. If you're asked to protein restrict, try and identify the precipitating factor. What did they come in with? That's the thing that needs to be treated that is going to improve the encephalopathy. If you don't feed the patient while they're encephalopathic, that will exacerbate it because they will use their muscle to feed them over that period. So people with acute encephalopathy, we feed usually because they need to be able to meet their protein requirements, which can be 80, 90, 100 grams a day. They're not really going to eat full hospital diet and consistently take sufficient supplements. So we would feed the acute encephalopathic patients, often the outcaps, 24 hours until the situation improves clinically. You do get problems with repeated tube removal. We use nasal loops quite a bit. The policy at the QE is that the patient removes their tube 3 times before that happens. We're trying to change that for the encephalopathic group because we know they're going to remove their tube 3 times. So if we can stop them, it's not because they don't want feeding, it's just because they're confused. So we feed them. With regard to chronic encephalopathy, meal frequency is very important. You might get people that say they get up in the morning, they feel fuzzy-headed, they're really drowsy, they have a bit of breakfast, they go back to bed. If they're not eating supper, they'll be catabolizing muscle and liberating a lot of nitrogenous waste overnight. So making sure that they've got supper helps preserve the muscle overnight. They're much clearer-headed in the morning. The same goes for snacks during the day. You need to prevent muscle catabolism. So get rid of any inappropriate restrictions that shouldn't be there, whether it's salt or whether it's protein. We see that much less, but we do see it. And I think there are still requests flying around for lower protein diets in some centres. Meal frequency, I've said. Supper, I've said. We meet the protein requirements aggressively, day in, day out. And particularly if you've got someone malnourished, you need to increase their muscle bulk. So if you need to do supportive NG or NJ, then so be it. But that's the way to increase the muscle bulk. And so you might get a referral for someone with this sort of subclinical or grade 1 encephalopathy to protein restrict them. But if they don't have enough muscle, if they're not eating snacks, if they're not eating supper, and if they're not meeting their protein requirements, then don't do it. If they're doing all of those things and they're still not improving, and they're having 1.5 grams of protein per kilo, for example, make sure they're not having boluses of protein, so they're not sort of washing down a cooked breakfast with a compact protein or something. Just make sure there's not a big load of protein at one time. And if the distribution is even across the day, then you could take it down slightly to like 1.2 incrementally, but only ever do it as a trial. Also make sure one of the first questions should be, are you on lactulose? And do you have your bowels open 2 to 3 times a day? And that needs to be quite soft and easy to pass. So anybody who's with chronic encephalopathy should be on that treatment. And lactulose, it's not just about emptying the bowel. It is about the fact that lactulose creates an acid environment in the large bowel. It reduces colonic pH to around 1 to 2, so prevents the replication of ammonia-producing bacteria. So it's not just the physical emptying of the gut, it's the climate. Steatorrhoea. Steatorrhoea is something that we address more and more and more from the point of view of biliary malabsorption. So we used to use whole protein feeds and higher fat feeds an awful lot more until we've understood that people with biliary malabsorption, so anyone with PSC or PBC, so diseases of the bile ducts, their threshold for fat malabsorption will be much less than people without those diseases, because they're diseases of the bile ducts. So they might experience these symptoms with bilirubin still in double figures, 70, 80, 90, or 50 with PSC. People without those diseases that get bilirubins towards the 100 have got cholestasis. They haven't got as much bile being delivered into the duodenum to emulsify the fats. So while you've got ongoing malabsorption, essentially, in simple terms, the liver is liberating energy to feed the patient, to feed the person. While it's doing that, it does another job, and the liver function is worse. So when you take the fat out and obviously replace it with calories, protein, the deficit you've created, when you reverse that malabsorption, you will improve liver function, and you can actually reduce the bilirubin as a direct result of that. We had a patient that was an alcoholic hepatitis, high bilirubin, but it had come down to like 200 to 300s on Peptisorb, low-fat feed, but you need to add protein to it, Prosource or something. Went to ITU to be filtered, no other medical change, and the consultant checked the notes because he didn't believe it. When we were talking about this, there was no other medical treatment. He was filtered, but he was changed onto Nepro, which is about 100 grams of fat per litre. Bilirubin went up to 600-700, came back to the liver unit, we changed the feed, and within 2 to 3 days, the bilirubin was back down to the lower hundreds. So the stress of the malabsorption and the fact that the liver has to liberate energy from elsewhere is the underlying thing here. So any patient that's jaundiced, screen them for fat malabsorption. It doesn't just have to be frank steatorrhea, gurgling, rumbling, distension, bloating, nausea, burping. Those symptoms that they're on a PPI, they don't respond, they still have them. That could be fat malabsorption. We've got a lady on a litre of Perativ overnight. She was on a litre of Peptisorb in hospital. Peptisorb's 10 grams per 100 per litre. Perativ is 20 grams. She's very full overnight with her feed. She's got a lot of belching. She feels extremely sick. Her bilirubin's gone up and she's malabsorbing. So she's putting on a bit of muscle, but her power's not getting any better. So this plays a massive role with our patients, but presents a very significant challenge. These are the last few slides. Nutritional products. This is where it presents the challenge. Since Nutricia foolishly did away with Fortimel, which was the perfect supplement for this group of patients because it was 20 grams of protein, 5 grams of long-chain fat and low carb for the diabetic population, we've really, really struggled. You can't use with the 300 calorie, 12 grams of protein, you'll never get the protein in that you need. You know, somebody might be eating comfortably 50 grams of protein. They need 100 plus. You know, they can't take 6 of those a day. But they need a 20-gram protein supplement. And also, these are really high fat, 10 grams of fat. So if you're jaundiced, no way, can't have them. The same goes for these. If you're jaundiced, you can't have them. So that's the Freshibin 2 cow, Ensure. You can't use any of these. The juice-based ones, they might be good if you're jaundiced, but they give you no protein. So again, the shakes cow shake, N shake, Scandi shake, loaded with fat, absolutely loaded, and only 12 grams of protein. Complan, in the powder, before you add milk, that's 7 grams of fat. So that's still, if they then add milk, you're getting into double figures. That's up to 10. And the same with Ames. Meritine, you can make with skim milk, and the powder has no fat, but it's not prescribable. So we use that in hospital, but we can't get it in the community. Fresh shake, it's great for protein, but it's got a really high fat content. So you can see there's nothing for the jaundice patient yet that's got protein in. We end up using an awful lot of Renapro, and there's a new one coming out called Renapro Shot, which is ready-made, small amount, ready-made Renapro, 20 grams of protein. It is high protein, low fat, low volume. So people blown up with ascites, people that can't tolerate the volume of supplements, people that have no appetite, we say you can make it up to 50 mils, you can make it with skim milk or water if you're jaundiced, and you take it as a medicine 3 times a day. The challenge with some is getting GPs to prescribe it because it's really expensive. But I think if you describe the benefits and give the anthropometry, it strengthens the case. The same with Prosource. Where people like it, we use it. It's quite hit and miss, but we use a lot at the company's grace. At the moment, we're looking to stock it of Prosource TF to top up our tube feeds because we only have Peptisorb. And we use Prosource down tubes, various different types of Prosource to top up protein and on the ward. So they're quite good. Calagen, ProCal Shot are good in non-jaundice patients for energy, but don't give anyone with a bilirubin in double figures Calagen because they won't absorb it. It's long-chain fat. You need to use Liquigen. So our usual tipples for people with, for jaundice patients would be one of these 2 and one of these. So Liquigen or the MCT ProCal powder as a good energy supplement that people can mix in. Beta Quick, information on the stands here, but that's a fairly new MCT product. And enteral feeds, this is just, you'll get this as a reference, but per 1,000 calories, the amount of fat. We use Peptisorb. We find that people can just about, with jaundice, tolerate this amount of fat, but it's 40 grams of protein per 1,000 calories, so we have to use TF or something else to squirt down the tube. Peptimon's on a par, and that's 6.5 grams of protein per 100 mils, so that's much better. Perativ, when you get up to a litre, you're getting up to 20 grams of fat, and Freshabin, the same, 20-25. So just be cautious. The best thing you can do for your jaundice patients is to lower their fat and increase their protein, and you'll get far better results.